the purpose of taking this case is, Bushra will also sit on one. Get one more chair. I think, Aksha, you can sit there. Get one more chair. Uh, आ जाओ तुम भी आओ. Come. We three can sit. Aksha. So the basic purpose of taking this case is to create an awareness amongst the nursing staff also, because they are very important part of our team, and these are the cases which we frequently come across. So with that background, may I request Dr. Bushra Fatima, Assistant Professor in the Department of Obstetrics and Gynecology, to start with a brief summary of the case, which are being managed by their unit.
So patient Mrs. A 23-year-old female, para 2+0, live 2, with VBAC delivery, presented to us on day 3 with continuous dribbling of urine. She was referred to us from a primary healthcare center where she delivered. So on speculum examination, an unhealthy previously stitched cervical tear with a rent of on the anterior wall of vagina of around 2 into 2 centimeters was seen, from which urine was dribbling, and Foley's bulb could be visualized through this rent. And another small fistula was noted in the juxtacervical position. This is the image here, and one fistula is this that we can visualize here, and one was deep here inside. So there was more than one fistula.
Okay, with that history, Bushra, please take your seat. Dr. Sahana, as the patient was admitted in your unit, what did you do after having a detailed examination of this case? How did you investigate? What all you did for her?
As soon as the patient came to us with such complaints, to begin with, we started taking the detailed history of the patient.
Take one. You can rotate amongst yourself.
So we have taken a detailed history of this patient, including the personal and obstetric history. So when it came to obstetric history, what is most important for us was the duration of the labor, where she was delivered, who conducted the delivery, and the mode of the delivery. Because as we know, the prolonged labor can cause avascular ischemia, tissue necrosis, and delayed presentation of the VBF. So that was important. Along with that, the mode of the delivery, whether it is vaginal delivery, was it assisted with the instruments, specifically the forceps, because more than vacuum, the forceps delivery can cause RVF or VVF kind of picture. Apart from that, so what was most important was the examination part. And in that general physical examination, we assessed her nutritional status. Apart from that, we did complete systemic examination, and in local examination, we examined her perineum, whether there was any injury, excoriations. If it's because of the urinary dermatitis, we wanted to assess that. And apart from that, we did digital examination, per vaginal examination and per speculum examination in OT under good light circumstances. So what we found was there was a large defect in the anterior vaginal wall, where we saw complete urine leaking through the urinary bladder and coming into the vagina. And aided with the per speculum examination, we could visualize the defect clearly. So we did not need any dye test or stress urinary stress test like cuff stress test, which would obviously make the diagnosis clear in case of small VVF, but in large fistulas like this, we did not need those tests. Ma'am, she came with continuous dribbling of the urine after delivery, post day 3. Ma'am, we were not sure who conducted the delivery, but she came from a PHC. And
so with that, what they examine in this case, would you like to add something? Like how should we approach when somebody has come following delivery with a history of leaking per vaginum? What all examination should be done?
Because we are getting quite significant information just on simple speculum examination, I think that will suffice in this case. Because if something is not clear, if it is like a crisscross fistula, when it is like a oblique course of the fistula, when we actually do not see the indentation or hole, then obviously we need few more investigation. When it is crystal clear, then I don't see any other reason to do any more investigations. But obviously cystoscopy could be one more investigation.
In that case, okay, cystoscopy.
I would like to add one point here. There was a previously sutured, there was a cervical tear which was previously sutured. So when they did the primary repair, they must have missed this large VVF. And it was in
But
the
that was
upper
following
third of,
delivery.
yes ma'am, yes ma'am. And it was in the upper part, upper 1/3 of the vaginal wall.
Anyway, she had a normal vaginal delivery, so maybe they could
Yes
not
ma'am.
have even touched that area which was higher up. Bushra, what was the primary care which was given by you people, your
Ma'am,
team?
as we'd seen that this was an infected, we could see that the cervix was infected, it was partly necrotic, so we gave her antibiotics for that, and we put in a Foley's catheter to, for draining, because it's been seen that small fistulas can uh, heal, around 15% heal spontaneously. Lower down, if, they tend to heal spontaneously. So we gave her antibiotics and removed any necrotic part, and um, Foley's drainage with Foley's catheter was given to her.
As you could see, a lot of slough was there. What do you say about doing washdown with hydrogen peroxide in these cases?
That is not the usual practice because we don't know the reaction of hydrogen peroxide for different patients react differently. But a good hygiene, even washing with normal saline will suffice because we just need something with little bit of pressure to wash the slough away. So I wouldn't use hydrogen peroxide, but just maybe lots of warm saline will be enough.
Dr. Naila, was she able to drain the urine through her catheter as her fistula was drained?
No, ma'am. She was not draining completely. She was not draining urine completely through the catheter since the size because the size of the fistula was large and there was more than one fistula present.
Was any amount of urine coming in the urobag, or all of it was leaking?
And most of it was leaking through the fistula.
Little amount.
So it was.
Around 500, 700 ml fistula, but the rest of it
Was. So if no urine comes through her catheter, do you still keep a catheter in situ?
If no urine comes out through the catheter means either the fistula is big or there are multiple fistula. But it is recommended to put the patient on conservative management initially, and we have to put indwelling catheter, whether she is incontinent also, because it is seen that researchers have said that studies have said that it leads to decrease in the size of the fistula, it leads to decrease in the infection around the fistula, it leads to decrease in the inflammation of the fistula tract, and it makes the fistula little healthy to get it repaired surgically later on.
Yeah, because we classify fistula according to their sizes. So if the fistula is less than 2 centimeters, 15 to 20% chance of it healing with a catheter in situ for next few weeks. So it's always a good idea. But if it's a huge fistula, and then a catheter may not make any difference, but still most of the time we will be putting a catheter. Yeah, because what we don't want is the bladder getting distended. Because if the bladder is empty, then it is likely the tissues will be likely to heal.
Dr. Roshan, how long to keep her catheterized if she is draining through her catheter and also leaking through the injured bladder? To put the catheter for around 4 to 6 weeks, 4 to 6 weeks, minimum of 4 to 6 weeks, for the entire tissue to get a little better than to reduce the inflammation, infection, and to make the fistula a little healthier, and to build up the patient's nutritional status so that she's prepared for a better surgery later on. So we usually put for 4 to 6 weeks and then reassess the patient after, and this Foley's is to be changed every 2 weekly. whether it is silicone or better to put silicone, but change it every 2 weeks.
Nursing students are also here. So if you have any question in your mind, we will give you a chance to ask that question. You can write the question and pass it through on a paper so that we can take up those questions at the last. Uh, so now,
Nursing students also need to understand that
yeah.
once they pass out, it is the nurses who are doing
Yes.
all the deliveries in the periphery.
Yes, Professor Zahra, that was the whole idea of keeping this discussion to help them in managing it better. So, Dr. Naila, how can you help your patient in dealing with her genital tract infection? As you could see, lot of infection was there, and how should care be provided to prevent any excoriation of skin?
We'll ask the patient to maintain a good hydration and to maintain a good perineal hygiene, changing clothes on regular basis, washing the perineum with soap and water, and for vulval dermatitis and excoriation, we can advise the patient zinc oxide ointment for application and sitz bath.
Any oil?
Ma'am, oil
Asha,
the
we would
as
like you to add something like when we were undergraduate and even postgraduate, we were taught because that time lot of VVF cases used to come. Now the incidence has decreased because of better obstetric care. So we were told that Vaseline is cheapest and best if you want to prevent the excoriation of the skin in a case of VVF. So what is your say for that?
The best thing about Vaseline is that it has only one single ingredient, which is petroleum jelly. Problem happens when an area which is traumatized and we apply something where the list of ingredient has more than 2, 3 items. It's not good idea because we don't know how the open tissue will react to it. For example, the double barrier cream or Diprobase or Dermol, things which we usually give to patients, dermatitis patient with lichen sclerosis and all that. But when you read the list, there are at least 7 ingredients. So they increase the shelf life, and these are preservatives and various things. And that makes you wonder what will be the effect of these ingredients. So that's why I have shifted myself so much to extra virgin pure almond oil. For any dry skin condition, and Vaseline I indeed use a lot because it has single ingredient of petroleum jelly and it is easily available. So Vaseline.
You were adding something now. Tell me.
I was
Coconut.
coconut oil.
Can it be equally effective? Because in our country we get more of coconut oil. So can it be as effective as almond oil?
So the benefit of coconut oil is that it is anti-inflammatory and antifungal as well as bactericidal. I don't know, but it is antibacterial as well. So these qualities are quite useful qualities there. But I think it's quite messy, isn't it? Coconut oil is quite messy for patients. It's very oil based. Almond oil is not sticky and it has no
Consistency is relatively
and it
thin.
has
That is
no
why.
smell.
Yeah.
Almond oil has no smell and it is cosmetically pleasing that it doesn't create a mess. But I think coconut oil can also stain your clothes. So,
Cheaper.
yeah. Yeah, but I don't see any reason why not. I think it can be used as well.
Thank you.
But it should not be rancid. You know, when coconut oil becomes rancid, it's not good. It should be
It's not
fresh
good.
coconut oil.
Dr. Bushra,
Good smell of
when
coconut.
will you decide to discharge her and call for the follow-up? Advice at the time of discharge.
So basically, these patients to be need follow up in the hospital. Only we know if she can be sent home telephonically, they can be contacted, and you can reassess them every 10 to 14 days. Then only you can send them home, and we advise them adequate hydration. That is at least 5 liters a day or 250 ml per hour. It is recommended so that there are no debris and there is urine is clear. And other than that, we advise perennial hygiene, sits bath, and that's it. No other antibiotic is required for in such cases
How
unless urine
about
culture
doing
is,
her urine culture?
ma'am, unless the urine culture is
And how do
positive.
you take the sample for urine culture? Because many postgraduates are sitting here. So we can have it
Ma'am,
from Dr. Afshan. How to take sample for urine culture in the case of VVF, where most of the urine is, she is dribbling.
If we ask patient to collect urine, obviously it will be contaminated because of vaginal flora and all that. So the best thing it will be to collect the sample yourself with a pipette on top of the syringe and just put it in the fistula tract and collect it from dependent part of the bladder. So collect it with a sterile syringe which has a pipette-like thing on the front. So you go in and you just take out some sample directly, because if you collect it from the catheter or the hole, it will be contaminated 100%. Yeah.
Ma'am, even from the catheter, it will be contaminated.
Because it is open environment from vagina.
Okay.
Yeah. Yeah.
How about taking culture from the fistula side, from the margin or from inside of the fistula? Will it help?
Culture swab, you mean?
Yeah.
Yeah, if you see obvious infection, you can do that, but sometime if there is no obvious infection, because if you are not planning to give any long-term antibiotics, yeah.
So, yeah, the bottom line is we have to be very careful when we are taking culture in these cases of VVF. So moving on, Dr. Roshan, you have done the catheterization, but as you could see, this fistula was very big and she continued to leak. So when will you plan her definitive surgery and with whom?
Plan the surgery after 3 months of Foley's catheterization, ma'am. We'll give this much time. And before planning proper evaluation of the patient, a cystoscopy to be done to look for the site and the size of the fistula, whether that is just a cervical or at the trigone near to the ureteric orifice. So after 3 months, a proper evaluation to exclude all the infection, systemic infection, local infection, the track of the fistulous tract, how is it, to rule out every infection like tuberculosis common in India, any helminthic infection, any schistosomiasis. So everything to be ruled out, and then well-planned surgery with a good team. If the fistula is still more than 2.5 centimeter near to the ureteric orifice, then better to do the surgery in a teamwork with a urologist and with a skilled urogynecologist.
You said tuberculosis. This was an obstetrical fistula. Still, do you think tuberculosis is
After
important for
three
her?
months, ma'am, proper evaluation of the patient is to be done.
All right. So, what are the investigations, Sahana, you will do in this case before her surgery?
Ma'am, before her surgery, I would like to identify all her comorbidities. And after identification, we need to control her if she has systemic hypertension or diabetes. It should be well controlled. And basic blood tests like hemoglobin, complete blood count, hemoglobin, to know her anemia status, blood grouping, and cross-matching in case if we are planning abdominoperineal larger VVF repairs through abdominoperineal resection. If we are going for major surgeries, then we need to at least arrange 2 units of blood products. Apart from that, urine routine microscopy and culture sensitivity in case the patient has signs and symptoms of UTI. And serology, HIV, hepatitis, and syphilis, VDRL markers. And we may have to go for ultrasonography to know if there is hydroureter, hydronephrosis. And as Dr. Roshan ma'am has rightly mentioned, cystoscopy in case of uterovaginal fistula, uterovesical fistula, or uretrovesical fistula, to know the size and location and to know if it is away from the trigone. And apart from that, in rare cases, IVP, intravenous urogram to know if there is any stricture and renal function is normal or not. This would suffice before the surgery.
I think that completes the list, or would you like to add some more investigation in these cases? No. So the list is complete. So what factor decide upon the route of surgery, Dr. Bushra?
So, ma'am, mainly, usually patients, what surgeons go for is the vaginal approach. Abdominal approach, because vaginal approach is, it has less blood loss, it is less painful, and it is relatively easy, especially the one that are lower down. But the one that are high up, especially in gynecological cases, some post-gynecological surgery, if any fistula develop, that is at the vault and that's higher up. Then abdominal approach may be required. And also when we are making positions for the patient, because steep Trendelenburg and lithotomy position is required. So occasionally when the patient is paraplegic, such positions are not possible for them. Then also abdominal approach may be required in such patients. So, yes, ma'am, it does matter, and the position also matters, whether it's a. And also, if we want to go for any additional surgery, we are it's if it's a complex fistula, then abdominal, both abdominal and vaginal, abdominal perineal approach may be required in those cases.
Would you like to add something?
When we have planned, going to plan her,
Yes, ma'am.
which may be after 3 months, what I would like to do is, once she's anesthetized and once we're going to do a cystoscopy for the patient, I will hold the cervix and see how much of it I can pull back, right? Or I would like to assess accessibility so that when we repair, we have a good field and we can do a good dissection and mobilize well. Then only we'll do it together. Otherwise, we will not. We will then discuss
Good
it
input
separately.
from Dr. Zehra.
Simple rule,
Very
as
nice.
I remember, simple rule for vaginal, for the option between vaginal approach and abdominal approach. What I remember is that if it is above the level of ischial spine in vagina, of course it is in vagina, then abdominal route should be preferred. And very important point, if it is very near to the ureteric opening, you have to do it through abdomen. You have to do it.
And in any case, you take a consent for opening the abdomen also once you are repairing, because sometimes it may not be possible to do it from below. So many case, you have assessed. But when you start doing it, you feel that it may not be possible. So every case, they should be counseled and consent should be taken for opening the abdomen. So I think
मैम एक शेयर करना चाहती हूँ एक्सपीरियंस when I was a very young beginner. I think I'm loud enough.
I
When I was a
think
beginner,
you are loud, but
or we
everyone
were
should see you when you are speaking then. You have so much of experience also, and
when
everyone
I was
will be benefited.
when I was a beginner like Bushra and Roshan, we had this case, and it was the surgeon who took the call, and he decided to do it abdominally. And because we had so little experience, we just let him go ahead. जब उन्होंने खोल दिया उसको, he realized that the fistula was so deep down, he couldn't access it abdominally. And it was then that I realized that every patient has to be assessed by me first, assessed proper, and I closed that fistula vaginally. He could not access it. वो तो helplessly खड़े रहते, and I was equally helpless. So we have to do our bit first, and then of course he couldn't. It was just a useless abdominal procedure. So मुझे उससे लगता है कि we must assess very properly under anesthesia, see how much accessibility it has vaginally, and then we decide.
So take-away message for everyone here is that the patient's pre-operative evaluation is very, very important. It has to be done by a gynecologist, preferably a urogynecologist, though in our country there is paucity of those who are having any special qualification of urogynecology, but at least the senior gynecologist who has seen a number of cases and can manage them better, and then only a decision for route should be taken. First route is vaginal. If that fails, a consent should be there to open the abdomen and to repair it abdominally. So with that, we have come to the last question for this panel discussion, and I'll request my colleague, Dr. Shazia, to go ahead further.
So, Dr. Roshan, post-operatively, what are the factors that ensure the success of the repair?
Proper drainage is to be ensured. The Foley should be properly tagged, that it is not kinked or it is obstructed. Second, avoidance of the local infection. Then adequate estronization and prevention of the bladder spasm by giving anticholinergics.
And one more thing, to instruct the driver not to take out the
Yeah.
Without asking the
Without, if anything, see, no. For this, I would like to give a very clear message that vaginal VVF repair surgery is a very difficult surgery, and we should make all effort after doing so much of hard labor that our outcome is good. To have a good outcome, we should have a very good nursing care and of course by the resident doctor on duty. Nobody should touch the patient. Inform the doctor who has performed the surgery. Even for a small thing, like if the patient say that, my operation is done and still my bed is wetting. Don't tell कि तुम्हारा surgery fail हो गया. Maybe there is some other issue. Inform your senior. That person will come and see. And I think nobody will ever refuse to come and see the person who has done so much of hard labor. And this is one surgery which has failure rate also. VVF repair is always not 100% successful. And I still remember one of somebody was telling the patient कि look, जैसे हिंदी में बोला कि देखो जो पेशाब की थैली होती है ना वो हर वक्त गीली रहती है, उसमें पेशाब आता है। तो जो अगर हम कुछ ऑपरेशन करते हैं तो वो जगह सूखी सूखी रहनी चाहिए। हम तुम्हारे पेशाब की थैली को सूखा नहीं कर सकते हैं। तो इसलिए ये है कि तुम्हारा ऑपरेशन कामयाब होगा या नहीं होगा, इस पे भी बहुत डिपेंड करता है। So that is true, like it's always wet with the urine and our effort should be there to do a very nice repair so that it does not fail. And we have some questions which are sent by the nursing and the question is, yeah, around the thigh and loose, थोड़ा loose होना चाहिए, under stretch नहीं होना चाहिए. So we'll take a few questions and this is as ma'am said to use soap and water for vagina and perineum cleansing. As soap contains chemical, will soap cause any irritation or any other reaction at the fistula site or around the perineum? Very good question and I will request Dr. Afsha to answer.
So there are different types of soaps. You know, there are some soaps with a lot of perfume and there are certain soaps which have no perfume at all. So we need to choose a soap which is very, very simple soap. And I don't know any marketing names here, but Lifebuoy, yeah, it's a simple soap. Yeah, simple and effective. Yeah. So any soap without perfume will be fine, less chemicals. That's
Other question is what step to follow to not to get to any UTI? If she has not any previous history of UTI, I think you have heard a lot about it, that drink lot of water, pass urine every 3 to 4 hours, maintain a perineal hygiene. Hydration is very important and certain drinks that you should not be consuming much like sugar and sugar-free drinks and all. The other question is also very simple, but if someone gets urinary incontinence very few times, like once in a month or 2 to 3 months, should she opt for treatment or does it come under UTI? Why will a person get once in a month urinary incontinence? Maybe that person has forgotten to pass urine on time. So what you heard in conservative management or non-medical, non-surgical treatment, that passing urine is important, maintaining bladder diary. Just listen, maintaining a bladder diary is important for a person who is getting it too frequently. Otherwise, a perineal exercise, which we have taught, will be of immense help. If somebody is having an occasional leak, very, very good exercise for controlling both stress and urge incontinence. Is it right to use lukewarm water by female if she has not any UTI or history of UTI? That means for washing, for perineal hygiene. I think they want to ask if lukewarm water is okay.
I think it is personal preference. If it is too hot weather, maybe you would like cold water. But there is no special benefit of lukewarm water. Water is water. So whatever is personal comfort and preference, that should do.
With that, I think 2 or 3 slides are there. I will allow you to ask that question. So only 2, 3 slides are there. This was the case which we managed around 2 or 3 years back. She was a case of road traffic accident. She was traveling in an auto, a rickshaw, and